At this time, if you have not yet completed the pre-survey, please pause this presentation to complete it before we move forward. To complete the survey, please scan the QR code on the screen or click the link titled Pre-Presentation Survey found in the email sent to you. Perioperative hypersensitivity, POH, is an unpredictable reaction linked to common medications used by anesthesia providers. Due to underreporting and lack of diagnostics, the overall incidence of POH is variable, with ranges to occur during 1 in 355 to 1 in 18,600 procedures. As this is likely not a surprise to you, anesthesia providers commonly associate POH with a group of medications called neuromuscular blocking agents, used to obtain muscle relaxation to optimize intubation and surgical conditions. Less commonly associated with POH is sugammadex, a neuromuscular blocking reversal agent. One study by Kim et al. 2019 shows that sugammadex POH may be as high as rocuronium-induced POH. Sugammadex is approved in adult and pediatric patients greater than or equal to 2 years of age who are undergoing surgery. Dosing of this reversal agent is based on the actual body weight, train of 4, and/or post-tetonic count evaluation. Administration guidelines state that sugammadex should be administered by bolus dose by IV route over 10 seconds. Sugammadex was approved for administration by the European Union in 2008. Due to anaphylactic reaction-related concerns, the US FDA delayed approval of administration until 2015. In 2021, the FDA expanded approval to pediatric patients over 2 years old. In a busy OR department, a 35-year-old male patient named Fred was scheduled for a laparoscopic surgery. Fred is 100 kilograms with no known drug allergies, no medical history, or history of anesthetic complications. After being administered a general anesthetic, his CRNA used rocuronium to induce neuromuscular blockade to ensure optimal conditions for this procedure. Following the completion of the surgery, it was time to reverse the effects of the muscle relaxant, and sugammadex was chosen as the agent due to its rapid action and efficacy. The CRNA assessed 3 of 4 twitches after train of 4 evaluation and subsequently administered 200 milligrams of sugammadex. After the CRNA administered the sugammadex, Fred exhibited no immediate reaction. However, within a few minutes, Fred's heart rate decreased into the 30s and his blood pressure also dropped by 30%. Luckily, the CRNA just watched this presentation and was aware of rare but documented cases of sugammadex hypersensitivity. The CRNA acted swiftly to stabilize Fred. The Ring and Mesmer scale 1977 is the most commonly used assessment tool to evaluate the clinical course of hypersensitivity reactions as illustrated in Table 1. Please note that grade 3 POH can be defined as cardiovascular collapse with or without cutaneous mucosal signs, as Fred presented in the clinical case study. The Sampson criteria is an evidence-based assessment tool that can help anesthesia providers distinguish symptoms that are indicative of anaphylaxis, as illustrated in Table 2. For example, a decrease in blood pressure greater than 30% from that patient's baseline. Of course, anesthesia in itself leads to a decrease in blood pressure. This tool is to serve as an adjunct that you can use with your clinical judgment and the overall patient picture. When early assessment of sugammadex POH takes place, management surrounds the preservation of the patient's airway, breathing, circulation, diagnostics, and prevention of recurrence. You can think of it as A, B, C, D, and P. In the case of sugammadex POH, the airway should be assessed and secured at the anesthesia provider's discretion. At a minimum, oxygen by face mask and continuous assessment for delayed onset of angioedema, respiratory involvement, or loss of consciousness is recommended. Severity assessment tools, as discussed, can help anticipate the requirement for intubation. Often, sugammadex POH reactions take place post-extubation and/or en route to PACU. In the review by Arlen et al. 2021, 18% of sugammadex POH cases did require reintubation. Rapid reversal of bronchial smooth muscle by sugammadex has been associated with bronchospasm. Standard recommendations to relieve bronchospasm are discussed across the literature. Epinephrine administration is an effective measure to relieve POH-induced bronchoconstriction. With the ability to ventilate, treatment with short-acting bronchodilators and sevoflurane is also recommended. Recommendations for refractory bronchoconstriction and the inability to ventilate include racemic epinephrine, ketamine, or magnesium. Standard of care also includes the administration of IV glucocorticoids, but note a delayed onset of at least 4 to 6 hours. Volume repletion is also centered on the severity of the POH reaction. At a minimum, a patent, fast-running, large-bore IV access should be established or maintained. In severe POH, peripheral vasodilation and capillary leakage require large volumes of IV crystalloid and colloid as first and second line replenishment. Literature recommendations encourage volume replacement between 20 and 30 milliliters per kilogram until hemodynamic stability is restored. This can be defined as a MAP above 60 or at a level that maintains coronary and cerebral perfusion and cardiac output. Epinephrine remains the first-line treatment for POH, but the differences in dose recommendations can be confusing in an acute and emergent POH reaction. The World Allergy Organization recommends an IM injection of epi in the mid-anterior lateral thigh when anaphylaxis is diagnosed. The dose recommendation is 0.01 milligrams per kilogram of 1 in 1,000 solution with a max of 0.5 in adults and 0.3 milligrams in children. Keep in mind that POH takes place in the OR, and therefore epi by the IV route is typically the first route of administration, and of course recommended to correct cardiovascular disturbances that typically present with severe POH. Interestingly, Arslan et al. 2021 found that 25% of anaphylaxis cases that presented with an indication for epinephrine did not administer epinephrine. Dosing of epinephrine can be subjective and largely based on response. For grade 2 reactions, the literature recommends doses between 10 and 20 mics to 10 and 50 mics of epinephrine. For grade 3 reactions, dosing starts at 50 mics for the initial bolus and increases to 100 mics followed by 200 mics if there's an inadequate response. Other recommendations range from an initial bolus of 100 to 200 mics every 1 to 2 minutes. After the third bolus, an IV drip can be initiated at 0.05 mics per kg per minute and up to 0.1 to 0.5 mics per kg per minute. Grade 3 reactions that are refractory to epinephrine can be treated with vasopressin and methylene blue at a dose of 1.5 to 3 milligrams per kilogram over 30 minutes. Grade 4 anaphylactic reactions commonly present as pulseless electrical activity. Recommendations for this scenario include CPR and standard ACLS. That includes the administration of 1 milligram of epi every 3 to 5 minutes until there is a return of spontaneous circulation. Due to the risk of cardiovascular arrest on presentation of cardiovascular collapse with paradoxical bradycardia, atropine should be avoided. Recommendations from the 6th National Audit Project, NAP6, recommend that CPR should be started with refractory systolic blood pressure less than 50 millimeters of mercury even without cardiac arrest. One of the limitations to the diagnoses of sugammadex POH is the lack thereof. Serum tryptase is a serum marker that is specific for mast cell activation and can be used specifically to diagnose sugammadex POH. Serum tryptase should be drawn within 30 minutes to 2 hours post-symptom onset. In addition, a basal serum tryptase level should be collected at least 24 hours after symptoms resolve and in conjunction with a complete allergy investigation. A specific algorithm of peak serum tryptase is used to compare peak serum tryptase levels to serum basal levels to determine the initial diagnoses. To prevent a potentially life-threatening re-exposure, a firm diagnosis is crucial. Drug provocation is the gold standard of drug allergy testing because it can confirm or exclude sugammadex regardless of the underlying mechanism. A positive provocation test results when hypersensitivity symptoms from the initial POH are reproduced. For example, in a case that presents with cardiovascular or respiratory compromise, a low dose may present with cutaneous mucosal symptoms. We have now discussed the clinical presentation and ABCD&Ps of management. But why does this phenomenon occur? How does it happen? And what does the clinical evidence show? While the exact mechanism of sugammadex POH is not fully understood, it is believed that sugammadex essentially elicits an immune response in certain patients. The chemical structure of an allergen and induction of sensitization play an important role in how sugammadex can provoke a hypersensitivity response. Structurally, sugammadex is a modified gamma-cyclodextrin. Cyclodextrins are a family of sugar compounds chemically bound by glucose units to form a ring. They're derived from a plant starch, and aside from pharmaceuticals, cyclodextrins are also used in food, agriculture, and environmental engineering. Typical cyclodextrins contain 6 to 8 glucose units. For example, an alpha-cyclodextrin has 6, beta-cyclodextrin has 7, and as illustrated in Figure 1a, gamma-cyclodextrin sugammadex has 8 units and forms a 3-dimensional ring structure with a hydrophobic core and hydrophilic outer surface. As illustrated in Figure 1b, you can see how the charged tails attract positively charged aminosteroids, rocuronium or becuronium, into the central core of sugammadex. It's the hydrophobic core of sugammadex that encapsulates aminosteroids, which are ultimately excreted unchanged in the urine. It's essential to highlight the molecular vulnerability of sugammadex as a cyclodextrin, because over 60% of POH cases are IgE-mediated. In the process of sensitization, exposure to sugammadex can lead to the development of specific IgE-Fc receptor complexes. Interestingly, Iwasaki and colleagues 2017 found that many patients who have experienced sugammadex POH had no prior exposure to sugammadex, which may be explained by cross-exposure due to the cyclodextrin-containing compounds. In my literature review, I found growing evidence to support a rare but serious association between sugammadex and POH reactions. For example, across the 4 to-date randomized control trials that explore the association of sugammadex and hypersensitivity, it is revealed that 1 in 20 patients will experience a mild or moderate hypersensitivity reaction, and 1 in 50 patients will experience a dose-dependent anaphylaxis. To date, a growing number of case reports and retrospective studies report the presentation and likely association of POH and sugammadex as well. From my findings, commonly identified themes associated with sugammadex POH include evidence of underreporting, dose-dependent reactions, bradycardia and/or cardiac arrest, and a potential genetic predisposition. These themes create several excellent clinical questions. Is Sugammadex POH underreported and underdiagnosed? Two recent meta-analyses evaluating Sugammadex POH warn that anesthesia providers should be aware that Sugammadex POH reactions, including anaphylaxis, are underreported in the literature. Is Sugammadex POH associated with increased doses? The jury is still out in response to this clinical question. Results were ambiguous across studies. Although there's not an RCT to evaluate Sugammadex administration over 4 milligrams per kilogram in the pediatric population, Voss et al. 2020 showed that adverse events defined as bradycardia, pain, nausea, vomiting, pyrexia, increased temperature did all increase after 4 milligram per kilogram Sugammadex administration when compared to 2 milligram per kilogram Sugammadex administration in the pediatric population. Is Sugammadex responsible for bradycardia and/or cardiac arrest? Despite the several case reports of bradycardia and cardiac arrest following the administration of Sugammadex, the explanation remains unclear. With no clear evidence that Sugammadex has direct cardiac side effects, it is postulated that the Sugammadex bradycardia phenomenon may be the result of a rare type of hypersensitivity reaction. One explanation is that mast cell activation ultimately leads to decreased cardiac output. Another explanation is Kuhn's syndrome, KS, which involves an interaction between an allergic reaction and the cardiovascular system. There are several case reports across the literature that point to KS as a potential cause of bradycardia and/or cardiac arrest due to coronary vasospasm after Sugammadex administration. Is there a genetic predisposition to Sugammadex POH? There are notable Sugammadex POH cases in Japan that may be explained by a genetic predisposition. However, this may also be explained by a greater overall exposure to Sugammadex linked to the earlier approval rates in those regions, anesthesia practice norms, and/or cross-reactivity with preservatives in Japan. The jury is still out on the answer to this clinical question, too. Several gaps exist across the literature due to the novel nature of Sugammadex, with great variability likely due to a lack of laboratory confirmation of Sugammadex-specific POH. Further research is needed to conduct more comprehensive studies that incorporate drug provocation to determine POH incidence, additional research to assess provider recognition of POH, voluntary reporting to increase anesthesia provider awareness, and lastly, randomized control trials have only evaluated Sugammadex administration as an IV bolus dose administered over 10 seconds. More comprehensive studies that evaluate the timing and speed of administration in association with POH are also needed. This concludes my presentation. I hope that you found it informative. Please scan the QR code with your cell phone or click on the link titled Post-Presentation Survey in the email sent to you. At the end of the survey, you will have a chance to obtain your $5 Starbucks gift card.